This conference will now be recorded.
Where we had left off last time, we've been talking about sort of the end of life for red blood cells. Um, and that end of life is, you know, 3 or 4 months into their existence. But there are also other reasons why we might get rid of them, why we might need to kind of take them out of circulation, or why they might remain in circulation but not function very well. And the first of these here is we're going to call anemia, right? And anemia is like, well, it's like cancer, or it's like diabetes, or it's like any of these other sorts of things where it's not, it's descriptive of the presentation. It's descriptive of the symptom. A lot of different things can cause it, right? And all an anemia is just when you basically suck at transporting oxygen, right? And there are a number of different ways that we can kind of arrive at that lousy point, okay? We can lose a lot of blood, right? If you get in a car accident and you lose your leg and most of your blood's on the car floor, it's not doing you any good, right? So blood loss obviously is an easy way to get anemia. We can also have problems producing red blood cells. We don't have sufficient quantities, or the ones we have get taken out of circulation faster than they're replaced. So for blood loss, this is either going to happen all in one go, right? So the sort of the gallon of blood on your floor, right? We call that a hemorrhagic anemia. Again, this is a traumatic kind of thing. This is an ER visit kind of thing, where you lose blood because it's on the ground. The other version of this is where it's sort of more of a slow drip, right? Like a leaky faucet. And we call these chronic hemorrhagic anemias. And this is where you have like an ulcer or a hemorrhoid or some other sort of slowly seeping or oozing wound that over time, that drip adds up. Right? It becomes a bigger issue over time. In both cases, they're pretty easy to treat. Cursors are interesting. There we go. If you have lost a lot of blood, we're just going to give you more blood, right? If you have an ulcer or a hemorrhoid issue or whatever, we're going to treat the ulcer or the hemorrhoid or whatever. Fairly easy, fairly straightforward things to fix. For lack of production, really the big one, the most common one sort of globally is iron deficiency anemia. If you lack sufficient iron in your diet, you can't manufacture hemoglobin. You can't manufacture hemoglobin, you can't transfer oxygen around your body. Again, fairly simple to treat. We just give you an iron supplement, right? Not too difficult. Where things get a little more problematic is in the last category, where the red blood cells themselves either get prematurely destroyed or they cease to function normally. So they might be out there, but you have a lack of functional red blood cells. And these things, we call these hemolytic, right? Lyse as in to burst apart. So the hemolytic anemias here can be because we've got weird hemoglobin. There's one or two really famous examples of weird hemoglobin. You can get a blood transfusion that doesn't match your blood type, in which case your immune system attacks all of those blood cells and kills them. Or various blood infections can also do the same thing. The usual cause of these here, outside of transfusion error, are these abnormal hemoglobins. Typically, this is a genetic disorder, sort of a genetically linked disorder. So thalassemia, sickle cell, stuff like that. Where the protein part of it, the globin, is abnormal in some way. And typically what this results in is what we call fragile red blood cells, where they tend to rupture or burst sooner than their time. So of these, really the two most common here, thalassemias. These are typical in people of Mediterranean ancestry, so Italy, Greece, Turkey, Sicily, places like that, parts of North Africa, have this kind of uh, predisposition towards these disorders. In this particular case, they're either missing one of the four globin chains or the globin chain is not functional. As a result, the hemoglobin doesn't work quite right. The red blood cells are fragile, and we have insufficient oxygen delivery. Now, depending on sort of the scale of faulty globin chain to absent globin chain, this can be pretty mild, right? But if you're missing one of the globin chains, it's actually pretty severe. Can be really problematic for people. Sickle cell anemia is sort of similar in that it has a genetic basis to it. Here, we're going to manufacture a type of hemoglobin called hemoglobin S, which has just one amino acid wrong in the beta globin chain. And what this ends up doing is when oxygen is being offloaded, so it picks up oxygen just fine, but when it starts to drop oxygen off, the cell itself actually sickles or kind of gets this sort of crescent shape to it. And the big issue there is that because they have this kind of sickle or crescent shape to them, they tend to clump and they get stuck, right? And they don't, when they clump or clot or get stuck, they don't travel down capillaries. And so we get downstream problems with oxygen delivery because we have a lack of blood delivery. So particularly like your extremities, your fingers, your toes are the first places we might notice some issues with this. If thalassemias are of Mediterranean genetic basis, the sub-Saharan African genetic origin here for people is where we tend to find a lot of this sickling. And this is sort of co-occurrent with what we call the malaria belt. There is, within the tropics, malaria is extremely prevalent worldwide. And it's still something that kills a ton of people. And it kills like 1 million people or something each year. Fairly easy to treat, but it still kills a lot of people. I don't know. There's socioeconomical reasons for that, I'm sure. But the reason that sickle cell and malaria coincide is that having one copy of the sickle cell genome confers not necessarily immunity, but resistance to malaria, right? And so you can imagine that if you have one copy of this, you still make functional hemoglobin if you only have one copy of it. So being immune or at least highly resistant to malaria would put you at a pretty strong advantage. It would be really, really strongly selected for, right? And if you have two copies of it, you end up with sickle cell anemia. Now, sickle cell anemia sucks, but it won't kill you like malaria will kill you. So even if you have sickle cell anemia, you're highly resistant to malaria. So even the worst case scenario here is better than dying of malaria. So it becomes fixed in the population. That's why it continues and persists to this day. Simply because of that ability to kind of have a resistance to a fairly deadly disease. Now, in terms of how do we treat this, don't really have good treatment for it. Really, the best thing that we can do is a blood transfusion that matches your blood type. We used to treat this with nitric oxide inhalation. Nitric oxide is what you get when you go to the dentist. You get sort of laughing gas. Truth be told, it doesn't do anything. It actually doesn't help at all. And again, there are probably some reasons why that persisted as a treatment in this population that are not really worth getting into here, but are pretty sad. So we're really kind of stuck with blood transfusion. We can try to prevent the sickling. When you are in utero, you produce a different kind of hemoglobin than when you do when you're an adult. So you produce what's called hemoglobin F in the womb, which has a little bit stronger affinity for oxygen. Makes it easier for you to remove it from your mother's blood. It's a whole other story. And then when you're an adult, you switch to a slightly less magnetic one, hemoglobin A. In people with sickle cell anemia, their hemoglobin F, their fetal hemoglobin, is perfectly normal. So the idea is that if we can just get people to make hemoglobin F instead of hemoglobin A, they won't have any of these problems associated with sickling. Um, and we've got some drugs that will do that. Hydroxyurea will do that. Um, there's been some suggestion that stem cell transplants, so replacing the hematopoietic stem cells that result in all of your formed elements, but red blood cells in particular, with quote unquote normal ones. Some promising results there, but stem cell and marrow transplants are pretty risky, pretty uh, difficult to pull off. What ends up happening with these guys is we go from a normal red blood cell like the one at the top. We change just one of these amino acids in the beta chain here, and we end up offloading oxygen and getting this kind of crescent or sickle shape to it. So again, you can kind of see how they would kind of maybe clump or stick together. On the other end of having sort of the anemic disorders where we lack sufficient oxygen delivery capacity, uh, we have situations where maybe we make too many red blood cells. So polycythemia, poly here meaning many, right? So polycythemia vera is when we typically we associate this with cancers. Uh, we have cancer. All cancer is unchecked cell division. That's really all it is. And so if you have cancer of like a committed cell for a red blood cell, you're going to produce just way more red blood cells than you would ever need. And the result of that is that blood becomes excessively thick, right? It becomes difficult for your heart to pump. So we actually start seeing wear-related damage to your heart. We see ruptured blood vessels, lots of unpleasant things that go along with this. There's also, in addition to polycythemia vera, there's also what we call secondary polycythemia, which is what happens if you go to Denver, right? And the air is thinner, and you compensate by releasing more EPO, and you make more red blood cells. That is usually not dangerous. That's usually your body's going to kind of operate within sufficient limits to make that not dangerous. But if you're Lance Armstrong or whoever and you're doing blood doping, then you run the risk of it becoming extremely sort of viscous, your blood becoming extremely viscous and it becoming dangerous. One of the first things we need to figure out when we have something as important as blood is how to keep it in your body. All right. So the process by which we keep blood in your body despite wounds to it is called hemostasis. And there's a lot going on here. We're going to keep this relatively simple, at least as simple as I can possibly make it. And we're going to kind of focus just on three simple stages for hemostasis, what the procedure is going to be like. The first step here, called the vascular spasm. And the idea here is all of your blood vessels have smooth muscle in them. And so the idea is if we can constrict the blood vessel, right, we can reduce the amount of flow through the blood vessel, we can reduce the amount of blood that we lose from a cut, right? So the vascular spasm is just kind of a pinching off of the blood vessel as much as possible to reduce the amount of blood that's going to flow past the cut and then out of your body, right? It doesn't work, like if it's your femoral artery, you're just kind of out of luck. It's not going to work well in something that big, but a relatively smaller blood vessel, because it's already pretty small, it's going to be more effective in those smaller blood vessels. All told, it's not the most effective thing in the world, but every little bit helps. Where we first start getting into things that help or that might help, we start talking about platelet plugs. And here, one of the only examples that we'll ever talk about of a positive feedback system, right? Where we do something and instead of turning itself off, it actually continues to turn itself up, right? So if we get one platelet stuck somewhere, it calls two friends. And then each of those two call two friends. And each of those call two friends. And so we go from 1 to 2 to 4 to 8 to 16 to 32, on and on and on and on and on, right? Until we kind of just literally just plug the hole with platelets. It's really all it is. And as these little chunks of cell fragment come together, because they've got kind of these broken edges, they're kind of sticky, right? And so they will stick to each other, and as they pass by, they'll kind of clump up and eventually fill the whole area up with these fragments of cells. Once we've done that, we're now kind of in more of a safety zone, and we can begin erecting kind of a more permanent, well, not permanent, but kind of a more long-term solution to our bleeding problem, right? And that's coagulation. And coagulation is basically what we're going to do is we're going to create a net of proteins. And in that net of proteins, we're going to trap red blood cells and other bits of stuff. And we're going to create what eventually is going to become a scab is what we end up doing. We squeeze all the fluid out of it and we create a hard, non-soluble chunk of stuff that can be there long enough for tissue repair to actually happen. That's the idea here. And there's a ton of these things called clotting factors that are a part of this. There are 13 of them, I think. We're not going to learn their names. Just if you know that the clotting factors are involved here, I'm happy about that. So, and we'll spend some more time with coagulation here in a minute. Our stages here, right? We have a cut, and so we start with a vascular spasm. We have a contraction or constriction of the blood vessel. We slow the flow of blood flow down through here. We fill that thing with a platelet plug, okay? And once the platelet plug is in place, we're going to begin this coagulation process. And coagulation itself has 3 stages. Really what I want you to remember out of the entire thing is that we're going to start with something called prothrombin, okay? And prothrombin becomes thrombin, and then thrombin turns fibrinogen into fibrin. And that last stage there, fibrin, becomes really important for us because fibrin is what we're going to build the clot out of. Okay, that's going to be the framework for us. So prothrombin to thrombin, fibrinogen to fibrin. And what we're going to end up with is we're going to end up with something that looks like this. So we've got all of this mesh back here. This is all fibrin. And in this fibrin mesh, or this net, we're capturing all these red blood cells. Okay? So this is the first part. We've created this mesh. Blood cells are getting trapped in here. Okay? And now what we're going to do is called clot retraction, or we're going to kind of squeeze down on this clot. And what this is ultimately going to be, right, is we're going to pull the 2 edges of our cut closer together. Right? We're going to take our fibrin and kind of just use it to kind of crank down on those edges, bring them as close together as they possibly can. And while we're doing that, we are also squeezing all, or most at least, of the liquid out of the clot. And so all we're going to be left with are fibrin and red blood cells. All of the serum is returned back to the blood. So we're left with a stable, relatively dense plug that has also begun kind of the process of bringing the edges of our cut back together again. At that point, we can begin repair, all right? And repair is going to be a process where we remove the clot piece by piece and replace it with new tissue, okay? There are a couple of things here. If you remember PDGF and VEGF, that's great. I'm not going to be super worried about that. Um, Really what I want to kind of get into is kind of the next part of this, which is fibrinolysis. So just made this fibrin clot, basically, right? But now it's in the way. It stopped the blood from leaking out. We've stopped the bleeding, but it's now kind of in the way of us repairing this tissue. So the process of removing it so that we can put in new cells where they're supposed to go is fibrinolysis. And the take home from this one, right, is really just this last term here, plasmin. Um, and plasmin is what's going to be removing that fibrin so that we have room for the new cells to go. But this is a relatively slow process, right? We don't get rid of it all at once, right? We kind of chisel away a little bit at the clot, we put in some new cells, we chisel away again, we put in some new cells. So that way we're kind of continuously advancing this growth while removing the clot at the same time. Eventually you get to a point where the scab can fall off altogether. Where this goes wrong, because invariably all of these things go wrong, are we call thromboembolic disorders. Okay, a thrombus is a clot, so we talk about platelets as thrombocytes. So a thrombus, thromboembolic disorders are times when we get clots that we don't want to have formed. The opposite of this are bleeding disorders where we can't form clots. We want to form a clot, but we can't form them. And then we've got kind of a combination of the two, which are the DICs, or the disseminated intravascular coagulation disorders, where you both clot too much and not enough, which is kind of a fun story to get to. But we'll get there when we get there. The first set, thromboembolic conditions, take one of a couple of different forms. Ultimately, what we're going to do here is we're forming at least one clot where we don't have a broken blood vessel. So if there's a clot formed without a broken blood vessel, it's called a thrombus. Okay. Now that thrombus might be stuck somewhere. Okay. And if it is, then that's just a thrombus. But if it's a clot that's floating through your circulatory system, it's called an embolus. So all emboli are thrombuses or thrombi, right? But not every thrombus is an embolus, right? All unwanted clots are thrombuses, thrombi. Only when they're actively moving are they emboli. Kind of a complicated set of terms, but it is what it is. The danger with both of these, right, is that if they get stuck somewhere, they can block blood flow. Right? If a clot in the way of blood flow, we prevent blood from getting where it's supposed to go. And that's an embolism, right? So if we have a obstruction of a blood vessel because of a thrombus, it's an embolism. And these can be long-term or short-term. The longer term they are, the longer flow is stopped, the more dangerous they are. You can usually get away with a relatively short-term blockage. Long-term, and by long-term I mean a minute or so, oftentimes is going to result in at least some cell death. The danger for Ebola or for embolisms is highest when they sort of occur in relatively risky places like your brain. So a cerebral embolism is a pretty dangerous thing to have happen to you. Pulmonary embolism can be pretty dangerous depending on circumstances. And you're more likely to get them if you've got conditions like atherosclerosis, where you've already got some blockage of your major vessels through the development of plaques and things like that. Swelling, inflammation can restrict blood flow through blood vessels. Being immobile. So one of the reasons we tell people to get up and walk around if they've been sitting down for a while is that blood will pool in your lower leg, in your lower extremities, your legs, if you just sit. And that can be a risk factor for clotting as well. And then when you stand up, your thrombus becomes an embolism, lodges its way in your cerebral artery, and you die. So we like to keep those things from happening if we can. Most common treatment for these things, if you have one or more of these risk factors, you might be prescribed aspirin. Aspirin is, among other things, it blocks a clotting factor, specifically thromboxane A2. I don't care if you remember that, but part of what it does is it blocks clotting factors. It does a job so well, in fact, that if you ever watched wrestling, and I don't know if you watched professional wrestling or not, I did when I was a kid. Um, One of the things they would do when they wanted to have a really big, like a big match at WrestleMania or whatever, they would come to the ring and they'd have like a razor blade tucked away in like a wristband or something, and they would go and they get slammed in the turnbuckle or whatever, and they would kind of discreetly pull it out and make a little cut in their forehead, so they would bleed. Prior to the match, they would take aspirin so that they would bleed a lot. So it's really an effective anticoagulant. There's a reason that we prescribe it for people. For pre and sometimes post-op care, we often use heparin. Heparin is almost dangerously good as an anticoagulant. So it's, again, one of those things we have limited application for, but when we need it, it's really quite good. If you watch golf or any other old white man sports on TV, you'll see commercials for warfarin a lot. Warfarin is actually rat poison, which is fun, but it's also an anticoagulant. That's why how it kills rats, but it's also something that we use here. And then things like dabigatran is kind of the new hotness with these sorts of drugs. The opposite side of the spectrum from a thromboembolic disorder are bleeding disorders. And typically what we have with a bleeding disorder is called thrombocytopenia. So thrombocytes, remember, are platelets. Penia just means not enough. And so thrombocytopenia means we don't have enough platelets. One of the signs of thrombocytopenia are these little pinprick bruises, usually on people's legs, but you can find them on most of their extremities. They're called petechiae. They happen when, in the normal course of operation, sometimes blood pressure is too much for relatively sensitive things like capillaries. They have really thin walls. And so not infrequently, we'll see a capillary rupture, just as part of normal function. With a bleeding disorder, they don't clot. And so we get these little tiny little bruises when they rupture. That's what a petechiae is. Lots of different causes here. If you are on radiation therapy, particularly of targeting bone marrow cancers and things like that, you can cause destruction there. Cancers themselves can actually also cause this. We're looking at a platelet count below about 50 grand per microliter. So there's a lot of platelets in circulation regularly. Anything below that number is pretty dangerous. But good news is if we know they exist, it's fairly easy to give you concentrated platelets, to give you some platelets in the interim, even if you can't make them. Another cause of these bleeding functions is liver damage. Your liver is responsible for initial manufacture of a lot of these coagulants, and so there's clotting factors. So if your liver is damaged through cirrhosis or vitamin K deficiency or hepatitis, it may impact your ability to make clotting factors, to make some of these things here. And so we get bleeding disorders as a result of that. So not directly related to platelet function, but instead clot formation. Probably the most familiar bleeding disorder are the hemophilias. Like some of the other things we've talked about, there are multiple things that all kind of end up in the bin of hemophilia. There are three major varieties of this, A, B, and C. They differ depending on which clotting factor is faulty. And I'm not going to ask you to remember which one. I honestly don't care. Hemophilia A is the most common. It's like 80% or something of all cases are hemophilia A. Hemophilia B, hemophilia C. C is the mild one. A and B are kind of intermediate in terms of their danger. They're not like you see in a cartoon, right, where somebody gets a paper cut and they bleed out. It's not like that. It's really more like you just can't stop bleeding. And it's not a gushing thing. You're not going to fall over dead. It's just you're going to have this kind of long-term slow drip of blood. Um, the big sort of immediate issue for people with hemophilia is they get bleeding into the joint cavities, right? You step wrong or whatever, and you crush a blood vessel, and all of a sudden your synovial cavity is filled with blood, and that sucks. It's really uncomfortable and really unpleasant. Um, Internal bleeding, if you get in a car accident, that can be really dangerous, um, more so than it would be for another person. So those sorts of things are what we associate with. It's not going to be the sort of thing that again, you get cut and you have to rush to the emergency room or you're going to die. It's typically not something like that. Ultimately, the big risk for hemophiliacs in the modern era is the relatively frequent blood transfusions these people get. Because every time you get a blood transfusion, you run the risk of a bloodborne pathogen. With testing being what it is now, those risks are lower, but not zero, right? You still always run the risk of getting something from a blood transfusion, even if it's been tested. The last variety here are DICs. This is where you're going to get both the best of both worlds. These are typical pregnancy complications. So things like preeclampsia can cause DICs. And what happens here is you have so many unwanted clots. So you have so many thrombi that are formed that you actually use up all your platelets. And then when it comes time to actually use them, you don't have any. And so you have a clotting disorder that leads to a bleeding disorder at the end of the day. And these can be pretty dangerous, especially for like as a pregnancy complication, because there's a lot of blood involved in pregnancy and delivery. So can be a major issue, both for you and for baby. It also has a complication of your various septicemias or blood transfusions or things like that. Now, as far as transfusions go, this is one of those things that I liked to be able to do in lab. Not a blood transfusion, but related stuff. Can't do it now, but was one of those things that normally we would do. A blood transfusion is, well, it is what it sounds like. We give you somebody else's blood. Time was, so this is one of those things that is one of the oldest repeated failures in medicine. Because it seems like a pretty straightforward idea, right? Somebody comes in and they've been stabbed with a spear or whatever, and they come back to your tent and say, "Oh, you don't have enough blood. Let's give you some more blood." And they would do this, right? And then the person would die anyway, and usually would die screaming, really in absolute agony. And then I thought, well, okay, well, let's not do that. They kind of gave up on the idea for a long time. This goes back to classical era Greece. And then they gave up on the idea for a while, and they would try it again a little bit later. So in the medieval period, it got sort of resurrected again. And they would do this with, because of the strictures in the Catholic Church, they would often use animal blood for this. So obviously that didn't work. In the Napoleonic Wars, they tried using horse blood. Obviously that didn't work. But they couldn't quite figure out why, if somebody didn't have blood, giving them more blood didn't work, right? And it wasn't until relatively recently that we actually discovered why a lot of these blood transfusions wouldn't work. Every so often they would work and the person would be fine, but usually they wouldn't work, and it would range from the person outright dying to just really not getting any better or falling a little bit ill. But what it was that we couldn't figure out was this notion of human blood groups, right? The idea that your red blood cells, like every other cell in your body, have a name tag, right? They have something that says, "Hey, I belong to so and so," right? And if you have the wrong name tag, that's what your immune system uses to recognize something that's got to go. So if you give somebody else's blood and the name tags don't match, that blood is going to basically be attacked by the immune system. It's not going to function as blood, and it can cause complications later on down the line. So we had to figure all that stuff out. And this is, I would say, extremely recent as far as medicine goes. Figuring out the idea that these things existed. And the term that we're going to use for these name tags, and we're going to keep this terminology as we move into the immune system here, is the term antigen, right? Antigen is going to be what our immune system looks for. It's the tag that the immune system looks for, determining whether something is your cell or not. So the first blood groups that we found we call the ABO groups, right? Based on the presence or absence of two proteins, A and B. So if you have the A antigen or the A glutinogen, I guess is the technical term for it. If you have the A protein, you have type A blood. If you have the B protein, you have type B. If you have both of them, you have type AB. If you have none of them, you have type O. And the way this is going to work is that if you have type A, right, your immune system is going to look for the A, right? It's going to be able to find that and say, okay, this belongs to us, right? If you have type B, right, it's going to look for the B and say, okay, if it's got B, belongs to us, it's all good. So what this means is that we have two different blood types that are going to be either a universal donor or a universal recipient, right? If you have type O, you have neither A nor B on there, okay? You're the universal donor because no matter what your immune system is looking for, it's not there. It's not going to recognize it as foreign. It's just going to accept it. So if you have A or B or AB or O blood, you can take O blood or give O blood rather. If you're type AB, you can get anything, right? Because you have both A and B. It's not going to look for one as foreign, right? If you have AB blood and somebody comes in with B blood, your immune system is like, oh, I see that. I'm looking for that. We're good to go. Or type A or whatever. So we have a universal recipient and a universal donor. Blood typing is really, really easy, which is why I like to do it in lab, but of course, can't do it. Basically, all you do is you take a drop of blood and you mix it with a serum containing an antibody against either A or B. And whatever one shows up, right, as this sort of clotting indicates the presence of that protein. So type AB blood then would react with both anti-A and anti-B. We would see this clotting occur here and there. Type A, we would only see it in the anti-A. Anti-B doesn't recognize it. Type B, anti-A doesn't recognize it, only type B does. And type O, because there's neither one present, there's nothing to clot, right? There's no interaction to have. And so this made a pretty big difference for us in terms of survivability of blood types or blood transfusions. Numbers went way up, but they weren't zero, right? They were not zero at all. And in particular, we started to see problems with mother-child blood type interactions, which we couldn't really explain. And it took until the discovery of the last part of your blood type, the Rh factor. So you're like O positive or O negative or AB negative or AB positive or whatever. That's the presence of one of these rhesus factors, named because we identified them in rhesus monkeys. The specific one is the rhesus D factor, but we don't need to worry about that. The vast majority of people in this country, this number is a little bit old, so it might be a little bit off from there, but the vast majority of Americans are positive. It's a very small minority that are negative for them. And the thing that makes these different is that you don't form anti-rhesus antibodies until you're exposed to it. So if you are Rh negative, if you're AB negative, and you get AB positive blood, no big deal, right? That first time doesn't matter. But with that first exposure, you start making antibodies against it. So if you get AB positive blood again, now we've got a problem, right? Because now you're going to be sensitized to it. Now you're going to have a reaction to it. So we're only going to see a transfusion reaction the second time around, right? With A or B or O, right, those primary blood groups, we see it right away because you make those antibodies basically at birth. But for the rhesus factor, the plus minus, it's only the second time that we're actually going to do it. And again, like I said, one of the big issues we were having was with mom-baby interactions. Mom and baby have completely separate blood, right? Baby makes its own blood, and that's why you and your mom don't share a blood type. You might, but you don't necessarily have to. Uh, and in fact, your blood never mixes. The placenta is a barrier preventing blood-to-blood contact. But what can cross the placenta are antibodies, obviously oxygen, carbon dioxide, nutrients, things like that, just not red blood cells. So what our issue here is when we have a mom who is negative and she gives birth. And again, if you've never seen even a normal vaginal delivery, there's a lot of blood. Everybody's blood all over the place. It's frightening, actually. It's kind of horrifying. But in that initial experience, if the baby is Rh positive, mom now gets exposed. Okay, and so she starts to make anti-Rh antibodies. If she has a second baby, and baby is still in the womb, but the second baby is also Rh positive, mom's antibodies can cross the placenta and will attack the baby's red blood cells. This is what we call erythroblastosis fetalis. Basically, the idea here is the fetal blood cells are being attacked and being destroyed. This can kill the child, right? It can be severe enough that it can kill the child. So one thing that we have figured out is that we can make something called RhoGAM, which is an anti-Rh serum, basically, that we manufacture and introduce to an Rh negative mother, which surprisingly enough actually prevents her from being sensitized in the first place, so that she can have as many Rh positive babies as she wants to. She won't have any antibody interactions with them. So pretty horrifying, scary thing, but we've figured out how to get rid of it. In either case, regardless of what the blood type factor is that's mismatched, an ABO group or RH group, the reaction is going to be essentially the same thing. Your immune system is going to go after those foreign red blood cells and agglutinate them or clump them, right? We're going to turn blood from something that looks like this into something that looks like that. And in doing so, a couple of bad things happen. Obviously, those red blood cells cease to be functional for us, right? So we don't have the delivery capacity we'd like to have. But also, because they're clotting and clumping, that can block blood vessels, right? We can actually get not only lack of oxygen delivery because of lack of red blood cells, we could just have lack of blood delivery, period. And this can be relatively minor, right? You can be sort of low-end anemia to straight up killing you, right? And one of the ways this will kill you is all of those red blood cells, when they get sort of burst or lysed, that hemoglobin just enters your plasma, and your kidneys filter your blood plasma 4 or 5 times, the whole volume 4 or 5 times a day. And as they do that, that hemoglobin can actually get trapped in and clog your kidney tubules, and that will kill you pretty fast, actually. So lots and lots of potential dangers with this. Right? Symptoms to look for in people post-transfusion, your typical anemic symptoms, right? Fever and vomiting are always a part of anything, but low blood pressure, rapid heartbeat, paleness, nausea, all those fun things. In the short term, right, a person isn't going to die from a lack of red blood cells in the short term. They will in the long term, but in the short term, your biggest concern is having them not die of kidney failure. So treatment for this is fluid, right? get that person full of fluid as much as possible. The more fluids they're processing, their kidneys will kind of swell and expand. And as they swell and expand to accommodate all the extra fluid, it's going to make it easier for that hemoglobin to pass. Okay, so we're just going to try to keep the person from dying in the short term while we figure out what happened with the transfusion. We'll call it good here. We'll come back on Friday. We'll continue talking about blood at that point. See you tomorrow in lab in the afternoon. Tomorrow is our last lab before the first lab exam, if I have that correct. So we will need to finish up the muscles we've looked at, and just a handful more we're going to add to the list.